So thanks for joining our panel, How Should I Really Manage Nasal Polyps? I'd like to introduce our illustrious panelists, starting with Arif Janjua, Associate Professor in the Division of Otolaryngology at UBC. Drew Ayers, who just spoke, Associate Professor and my partner in Allergy and Immunology at UW. Sanjay Parikh, another one of my partners and professor at Seattle Children's. Jeff Suh, Associate Professor at UCLA. And then finally myself, as Greg mentioned, I'm an Associate Professor at UW. So the objectives of this panel discussion are to describe how to efficiently work up different forms of nasal polyposis, understand the management of nasal polyposis as best you can in 30 minutes, and outline the role of primary and revision endoscopic sinus surgery in the control of this disease. We're going to start by making the right diagnosis. Traditionally, chronic rhinosinusitis has been stratified into this kind of binary division based entirely on phenotype, entirely on that nasal endoscopic exam, into those with and without nasal polyposis. And the issue with that's increasingly come to the fore is it doesn't really account for any of the underlying pathophysiology. It's been shown time and again that this is insufficient for targeting treatment options, predicting how well a patient's going to do on treatment, and understanding over the long term how they're going to manage with their disease. And there's this increasing push to move to this disease-based classification based on endotype, which is a unique pathomechanism, so the underlying immunology driving that particular case of chronic rhinosinusitis. And this is part of that overall push towards kind of personalized medicine. To be honest, our understanding of endotypes right now is actually relatively controversial. There's a whole bunch of different classifications that have been proposed, and our understanding, frankly, is quite rudimentary. That said, the most recent iteration of the EPOS guidelines, which is the European Rhinologic Society's statement from 2020, has tried to work endotypes into stratification of disease and diagnosis. And the way they've done this, again, it's relatively rudimentary, and I imagine over the years as our knowledge of the pathophysiology improves, this is going to get more and more granular. But as it stands, you look at primary chronic rhinosinusitis, so that's disease that began in the sinonasal cavity and not from some other underlying systemic disorder. And it's initially classified based on anatomic distribution. So this is localized disease, unilateral or in one sinus or just a couple of sinuses, or is it more diffuse, where it's essentially affecting all of the paranasal sinuses? And then we're looking at endotype, and thus far, really, we're just looking at type 2 responses, type 2 immunologic responses, or not. If you look at the diffuse bilateral primary chronic rhinosinusitis, the type 2 classification are typically those with nasal polyposis, and that includes a variety of different diagnoses here. You've got your chronic rhinosinusitis with nasal polyposis, which more correctly is called eosinophilic chronic rhinosinusitis. You have your allergic fungal rhinosinusitis, which we're going to touch upon, and then this recently described entity from the team at Emory, CCAD, or central compartment atopic disease. That said, you can also have localized type 2 responses, and that's most classically shown in AFRS, which not always, but most of the time is a unilateral disease process. It's important to note that even in your non-eosinophilic, so your non-type 2, diffuse chronic rhinosinusitis, you can have nasal polyps, and this is particularly true in the Caucasian population. So if you're looking at the Asian population, if you're looking outside of kind of the Western nations, China, Southeast Asia, the vast majority of their polyp patients actually have a non-type 2 polyp disease. And then this is what we're not really going to dig too deep into, although I'm going to ask Sanjay here a couple questions about this. Our secondary chronic rhinosinusitis, so this is kind of a systemic disease that's driving polyp growth. Primary ciliary dyskinesia, cystic fibrosis, Sturge-Strauss, Wegener's, and the like. All of you already know the diagnostic criterion based on cardinal symptoms and objective findings, so we won't drill down on that too much. But I'd like to ask the panel, and we'll start with Arif. Are there elements in the patient history that allow you to differentiate between those different forms of primary chronic rhinosinusitis that we just talked about?
I talked about this earlier this afternoon, and I think that we can find some markers of that eosinophilic pattern, that those type 2 patients that have asthma, that have atopic dermatitis, the coexistent type 2 inflammatory patients, both histopathologically, like I talked about, and history. I think there's enough there to tell us about the dermatitis patients, the eczema, the asthma.
Specific questions that you would ask to help kind of tease out these diagnoses?
About an eosinophilic etiology?
Yeah.
I'd ask more so about history. Then if we're talking about sinus disease, about smell, focusing on things that are going to be particular to type 2 and polyp patients. I like those ones. Beyond that, I think questioning is hard because people give us the impression of my sinuses don't work. It's hard for them about the thick discharge, I think, is a strike against those people. But the polyp patients' absence of sense of smell, that being their early presenting feature. Maybe one of the big ones.
Jeff, anything to add in terms of kind of history taking in your diffuse bilateral nasal polyposis patient? Kind of tease out that underlying diagnosis. Anything else that you'd ask?
On the previous slide, there were some other conditions that are there, like vasculitis, CF, PCD. Sometimes you can get some things in the history that suggest a long-standing, maybe genetic condition,
right,
that are important to pick up because the management afterwards would be different. Maybe the size of the surgery you would do would be a little bit different.
And then following on from that question, what are these red flags that might come up that make you think, okay, we're not even talking about an inflammatory process any longer. This is something that I need to take really seriously. There might be something else going on here.
Well, yeah.
What?
Unilaterality.
Right.
You know, those kind of things that imply an ulcerative inflammatory process, right? We want to try to figure out that edematous inflammatory process from the ulcerative inflammatory process because those are two different animals.
Right, and also questions obviously about systemic disease, right, outside of just the sinonasal cavity. You can kind of break this down, and again, this is just a summary slide. If you're looking at eosinophilic chronic rhinosinusitis, often middle-aged patients, not always, very strongly associated, strong concurrence with asthma in particular. And as far as cardinal symptoms, there's a little bit more of a bias towards presentation with nasal obstruction and hyposmia, more so than the other two cardinal symptoms, your nasal discharge and facial pain. There are other features specific to folks with aspirin-exacerbated respiratory disease, kind of a worsening of their symptoms on alcohol intake, as well as, of course, the classic, as Dr. Ayers just spoke about, NSAID and aspirin sensitivity. On nasal endoscopy, you kind of see this diffuse polyp picture with kind of this thick eosinophilic mucin. Of course, there's allergic fungal rhinosinusitis. Tends to be a younger patient population. There are some associations, and they're kind of listed here. Geographic preponderance is important. So southeastern United States, a ton of it. I think Dr. Levine was mentioning that they do a lot of this in Miami, certainly more than we likely see up here. And then the symptoms, often unilateral, not always, and frequently present with total loss of their sense of smell. And then on endoscopy, again, you see this almost pathognomic peanut butter consistency eosinophilic mucin. Central compartment atopic disease, probably the most recently described of these entities. Early age, severe allergies. Their skin prick testing is obviously, or is often floridly positive. Very rarely have lower respiratory disease. Symptoms of allergic rhinitis, their smell tends to be intact. And then interestingly, their nasal endoscopy has this kind of very characteristic central distribution where they have polypoid change in those central structures. You're talking septum, leading edge of that middle turbinate, kind of sparing the more lateral aspects of the nasal cavity. And then finally, your non-eosinophilic CRS, which, like I said, can be either polypoid or not. Middle age, a variety of associations, again, listed here, often present with facial pressure, interestingly, as opposed to your eosinophilic chronic rhinosinusitis, where that's less of a feature. Again, not a constant, but just a little bit of a flag to kind of point you in the right direction. Other features, a prior history of non-responsiveness to steroids. So that's important to try and tease out. And then finally, the endoscopic examination. Rather than that eosinophilic mucin, you're seeing this frank purulence straining out of the sinuses. I'm going to move on to Sanjay here. When do you elect to obtain imaging in the workup of nasal polyposis? Is this something that you kind of do up front, or are you going to treat them medically first and then shoot a scan later? It might be different in the pediatric population.
Yeah, so for me, imaging is only indicated when I'm heading to surgery. So I don't use imaging routinely because of the risks of exposure to kids with radiation. But I think that principle can apply across the board. It's not going to change your diagnosis here. You know you've got diffuse nasal polyposis. Maybe it'll help you if you have a unilateral case and if you're thinking more about tumor or AFRS. But for me, it's definitely the workup is non-imaging related. It's findings on endoscopy bilaterally. And most of the patients I see with nasal polyposis have some underlying condition, mainly cystic fibrosis, PCD, immunoglobulin subset deficiency are also in the patients I see. And in those patients, we need to do a sort of multidisciplinary evaluation. And I'm big on that. And I think having Dr. Ayers on this panel is really helpful, because I almost I like to take care of anyone with polyps in kids unless I've got additional teammates on board before I even go to the OR.
And Drew, we've got some questions for you coming up in just a second here, but I'm going to jump back here to Ara for a second. So AFRS patient, for example, are you going to try them on oral steroids and the like and say, all right, come back in a month or two and then I'm going to scan you, or are you going to scan them up front and say, you know what, this is a surgical disease, or you're going to the OR? What are your thoughts on that, just as an example?
Yeah, I was interested to hear your thoughts about kids, and I understand the ionizing radiation. I would say all my patients where I see polyps, unilateral for sure, but almost all people, I want to get a gauge about the baseline or the extent of the disease. And I understand why you don't, but it's interesting paradigm, because even if I'm not going to operate on those people, which I think would be rare when you see significant polyposis, to get an idea about chronically where you're at this time, so we can kind of track that.
When are you going to do it? Before or after medical therapy? Always medical therapy up front and then the scan? Or are there exceptions?
Yeah, I think there's exceptions. I don't necessarily, the timing piece is not something that happens for us instantly, so
Right.
that part is a bit different, but I think that the issue becomes that it doesn't matter to me. I think I will take into context whether they've been maximally topically treated when you have that scan, but I don't really necessarily care when it came.
Jeff, I'm going to give you an opportunity to comment on not only that first question, but also the second one as to whether or not imaging allows you to differentiate between these different disease entities.
Oh yeah, absolutely. You know, like AFRS, fungal sinusitis, there's different characteristics, things that you'd pick up on the CT scan, like the different densities, maybe some thinning or erosion, versus maybe non-AFRS, where you can have, diffuse, I don't know, kind of like osteogenesis in the same sinus cavity. Yeah, I think the CT scan can kind of clue you into different diagnoses, and also in some ways kind of prepare for the discussion you're going to have with the patient about the particular risks in that particular surgery.
Any role for imaging modalities beyond the CT scan?
Yeah, so as a follow-up, if there's significant amount of erosion, or if there's something that's concerning in terms of a unilateral disease, that's worse than one side than the other, an MRI scan can definitely help to kind of identify issues with the orbit in the brain, tumors.
Great. I'm going to jump back to you for a second. So AFRS can result in significant bony destruction, right? And we know that. We've seen orbital invasion with this. We've seen intracranial extension. But so can really terrible things like malignant tumors. Any pointers on how to avoid missing the can't miss diagnoses?
Yeah, I think Karina showed a really nice case of it that you could very easily have said, wow, what's going on there? The supraorbital rim had been totally eroded. It was herniating into the orbit. I think my pointers would be windowing. Be careful with your windowing on the CT. You can get a lot by just changing the windows that you can. And then advanced imaging. If you have a question about it and you want to figure out whether that is mucosal, trap secretions, that MRIs can help you in that way, as well as some of the additional features. It's funny because these things, AFRS, happens relatively slowly compared to a tumor, and so some of the features that would come with expansion in that area don't happen. Even if you get expansion of your maxillary sinus because of a huge amount of double density and fungal mucin, your V2 is not gone. If that happens in a tumor, or if you have any kind of cranial nerve deficits, I think you've got to be...
Right, and that indicates the importance of the history, of course, as well, with these kind of adjacent symptoms, facial paresthesias, that sort of thing. I'm immediately thinking this could be something non-inflammatory. So just to kind of summarize, eosinophilic CRS findings, often it's a bilateral pansinus opacification with either subtotal or total opacification of your sinuses. There can be some bony remodeling, neo-osteogenesis. AFRS, very different on CT. You can see that above. You get the signal heterogeneity from the hyperdense secretions and bony remodeling as well. And that can include expansion of the bone, but it can also include dissolution or dehiscence of the bone as well. And the MRI in these sorts of patients, and often, they come in with this unilateral process, so it's not uncommon for them to end up with an MRI. You get these signal voids because of the concentration of metallic ions, calcium and iron in the fungus as part of the fungal metabolism. central compartment atopic disease. We talked about this before. You get this scan, and all the opacification is it seems to be outside of the sinus. It's kind of in the central nasal cavity area. This is a little bit of a confusing scan because I've got a secondary obstruction of the maxillary sinus. What's happened here is that all that central polypoid disease has basically lateralized the middle turbinate. So you're getting this post-obstructive effect in the maxillary sinus.
And Sanjay, that's the one that helps me, I think, because sometimes I look in that nose and it looks horrible because it's all right in view of the endoscope, but getting the imaging tells me that, it's not everywhere. It's not like the complete whiteout that we saw on the slide back, and then that's what I mean by the CT kind of helps me score or grade their degree of disease, which I think you are handicapped by not having.
Yeah, I think maybe because I'm not thinking about polyposis in this sort of eosinophilic and non-eosinophilic sort of mentality. I'm thinking more about PCD, cystic fibrosis, and immunoglobulin subset deficiency, but I see your point completely.
And so touching upon that, Sanjay, so somebody comes in, pediatric patient with nasal polyposis, is that a reflexive sweat chloride test or cystic fibrosis genotyping for you?
Yeah, I think the history drives that. And one of the red flags I just want to point out is recurrent childhood pneumonia. I mean, I think all of you guys should ask that question when you see patients with diffuse polyposis. To me, that's a huge red flag that you've got some sort of underlying condition. And certainly chronic otitis media fusion points to PCD. But getting back to your question, I think diffuse polyposis to me is just generally a red flag that this is not normal. It's not something we see commonly in kids.
Right.
And right away I'm thinking CF, but most of the kids I see have already been diagnosed with CF. It's seldom that someone's got over it, but I have had a couple of kids over, long time where polyposis was their initial presenting finding. But I think most of the pediatricians out there are so astute to this now that it just becomes right into the diagnosis. And I'm really excited. I just want to also plug, while we're talking about cystic fibrosis, I didn't see it, I don't know if we're getting into it, but talking about the CFTR gene modulators, and that's this huge, incredible thing that's changed the sort of outlook for chronic polyposis in children with cystic fibrosis. These new medications like Trikafta and Ivactor are these cystic fibrosis transmembrane regulator proteins that gene modulators. So this protein doesn't function well in kids with cystic fibrosis in the respiratory epithelium. So chloride and sodium can't get through these channels. And these medications actually lock the channels open so that sodium and chloride can now exit, and so you now have normal appearing sweat as opposed to this thick viscous ones that they get. And that's been a game changer. There's been there's something just came out last couple months from Brad Woodworth's group looking at this. It's saying that in nasal epithelium in an animal model, it actually improves sort of the function. We don't have good data yet for sinusitis. I don't know if you guys anecdotally have seen cystic fibrosis patients improve with it, but I'm excited about it. I'm excited about it for the patients. I'm sad for me. A little less surgery, but
yeah, I think on the adult side or in the older CF patient, I'm certainly seeing less sinus surgery since the introduction of these ion channel modulators. Non-eosinophilic chronic rhinosinusitis, very difficult to differentiate on just a scan from your eosinophilic CRS. I'm going to ask this question to Drew. So in this era of biologics, is it useful to have a tissue biopsy? So, I don't know, eosinophil levels and the like per high power field and the various other parameters that we can look at on tissue. Is that useful?
That's a good question. I mean, I think we were talking about this recently. I don't know of any data that say that guides one way or the other, whether that would be an anti-IL-5 or anything like that. We always do get CBC with differential, look for eosinophils, look for total IgE. I look for allergic sensitization, especially if I'm going to be prescribing something like omalizumab. But it's an interesting question because there are different forms, and if they don't have that eosinophilic, if it's more a different type of inflammation, they're not as likely to respond to these biologics because they go after that Th2 endotype. Like when we prescribe for asthma, we have to document they have an eosinophil level of a certain level. If we're going after, again, omalizumab, we have to document they're sensitive to perennial aeroallergens, and they have to have a total IgE above a certain level. So as far as nasal polyps, I don't know. It's a great question as far as biopsy and whether that would be helpful or not. You think if it was chock full of eosinophils, more of the the Th2 types, they're more likely to respond. It's a good question.
Any of you guys, anybody else on the panel, just do biopsies to help guide further management? Does it feel like
I'm
it helps?
interested in it, and I don't know the answers yet, but it's something that our lab at UBC is trying to work on, is the idea that the nose is such a great window into the unified airway, is that you can't take lung biopsy so easily. But Jeff mentioned how his setup is such that he can divide a recirculating band. If he can do that just as easily, he could take a polyp biopsy and look at eosinophil counts per high-powered field, and I think it would give us a way. Now, a lot of people have tried to use surrogate measures for that, like serum blood testing about eosinophil levels. And I think we're starting to see that that could be maybe used as a pointer, that it pushes you in that direction. The problem is IgE levels, not that, I'd love to hear everybody else's thought. I just don't find them so predictable. When they're sky high, they're great, because it sort of is a slam dunk. It's the people, we already kind of knew them. They have dense fibrotic polyps. They've come back several times. We knew that they were bad eosinophilic polyp recurs.
Could the biopsy help guide you with perioperative steroid management? You know, because one will probably be more sensitive than the other.
I bet you it could help you in a whole bunch of different ways, which is the timing. We were talking about timing of ASA desensitization, biologics around surgery time. There's going to be a lot of data that comes from this day to the next 2 years about what about starting them on biologics just before your surgery to try to optimize that field and then continuing it through. So the pair, just like we did with steroids, we used to not use them and only use them after surgery, use them before to prep for surgery. Now bridge surgery times. I think biologics are going to replace that in a steroid-sparing way.
Drew, if I'm thinking of sending a patient over to you, are there tests that I can get beforehand that'll facilitate the workup and just expedite care?
You know, for nasal polyps, no, because we don't need to document, at least in my experience, eosinophil level above a certain, allergy testing we can obviously do in clinic. If they're more atopic, they're more likely to respond, I think. For asthma, yes, that really does help because we have an eosinophil level, we have an IgE, and that just tells us whether they're even candidates. Because if we apply and their peripheral eosinophil level is so low, then we won't get it approved. But with nasal polyps, not necessarily. Most people have had CBC, hopefully off prednisone, but most people have had, and in my experience in the patients, certainly we share, most of these patients do have, high end of normal EOs or abnormally high EOs. And I think that's just a clue they're going to respond, but I don't have great data to say that's the case. It's a great question.
And the companies don't make you, is just seeing polyps is enough. Your otolaryngologist seeing polyps is enough.
And that's why when we're talking back and forth, I need to see that, polyps were documented on
Right.
rhinoscopy before I even apply for that. Because if you don't have it, we're probably not going to get it approved. So, I always talk, with
So there you
Greg
go.
or Waleed.
Don't get a battery of tests, just document those polyps.
They may have some in the future say, oh, you have to have this level, but for now, we haven't run into that issue.
So this table here shows kind of evidence-based medical interventions on the left side there per the ICAR and EPOS documents, so the American kind of consensus statements and the European. And we're not going to drill down into this in too much detail, just to highlight some key differences. So your eosinophilic chronic rhinosinusitis, highly responsive, at least in the short term, to oral steroids. Less so in your non-eosinophilic population. Like I said, something to tease out from the history in terms of the responsiveness to prior courses of steroids. In those folks, anti-inflammatory antibiotics, so specifically the macrolide class, and then more recently, the tetracycline class as well, so doxycycline, administered for a period of about 21 days, can induce a significant, again, relatively short-lived improvement in quality of life measures. And in the interest of time, we'll just kind of move on here. What's an appropriate duration of medical management before you consider disease refractory? I'm going to ask this to Jeff.
Yeah, so this is a really important question for all of us that make the decision to do surgery, and something that I talk to my residents and fellows about is that you really need to understand the disease process. If someone comes with you with a fungal ball in the max raised sinus or odontogenic sinusitis, throwing Flonase and irrigation is going to have no effect. And we have to be smart. There's some people that you just say you need to do surgery or you're not going to get better, and you just recommend the operation for those reasons. But there's some people that have certain disease or patients that are kind of leaning away from doing surgery for different reasons. And you could do medical therapy as long as they want. I mean, this is a condition for people's quality of life, and you would never force someone that has nasal polyps to do surgery no matter how bad it is. So I think it's,
Jeff, can I ask
yeah.
Have you seen a complication of nasal polyposis? Orbital abscess, brain abscess, because I haven't. And that, it makes me feel good that waiting is okay. That's the one thing I worry about.
Go ahead.
Yeah, no, you're right. You know, I think most of my experiences with complications of polyps are maybe ones that have fungus at the same time, but not really straight nasal polyps.
So there are many different forms of intranasal corticosteroids, a whole bunch of different delivery methods, and then as concisely as you can, Arif, what are your thoughts on the different options there? Any particular preference, pre-operative and then also post-operative?
I'll try to be, that's a huge topic, and I think we can talk forever on it. I think what I said earlier today was figure out if you think they're going to be steroid responsive, if they're going to be in that eosinophilic category, and if they are, try all of those. Now, I have my own personal thoughts about where that works. I think delivering things through a larger volume that can move around corners makes sense than someone who has polyps hanging and you need to get delivery of medication through the entire nasal cavity. So I don't find steroid, and I think they work differently in different places in the nose. So steroid sprays work really well for the inferior turbinate area, the anterior portion of the nose, but don't work really well for polyposis that's global and at the back of the nose as well. Sometimes I combine them for that reason, so that I'll use something for the anterior portion and something for the posterior. In the postoperative period, interestingly, immediately I'm trying to do the flushing because I want to clear out all the debris and leave steroids behind, so steroid impregnated rinses. But when they heal, I switch those people back to nasal steroids because Jeff's created those beautiful cavities he showed us where the steroid sprays go right in and go right into the frontal recess. We don't need to use time-consuming, expensive topical therapies. To get them there, yes. As maintenance, I kind of go backwards. I don't know if you have a different approach.
Yeah, I'll say that I approach it a little differently. I think that there's been a lot of published data based on kind of computational fluid dynamics in the postoperative cavity, showing that you can still optimize treatment by using these high-volume steroid rinses, for example, versus your classic aerosolized Flonase spray. A little bit different with some of these newer exhalation delivery systems, but certainly the high-volume steroid has now become my workhorse. Jeff?
Yeah, so, you know, it's funny, 10 years ago when I came out of training, we would start people on steroid washes twice a day, and then the goal was to eventually get them back to nasal sprays. And then I kind of changed my mind. I was like, well, why am I trying to get them on nasal sprays if the steroid irrigation works really well? Now I'm kind of in the middle where it's really hard to have people rinse twice a day with steroid washes all the time. So I had this great other option with the exhalational sprays. So maybe they'll do once a day with the steroid wash and then once a day with the other spray. Right. And whatever works. You know, we see these polyp patients back so often that if in 3 or 4 months when you change the intervention it's not working, then you switch them back to what was working.
I like to have a plan and mix it up based on what I can't get to it. The morning is so hectic, I can't do a wash. Okay, we'll use this exhalation device. It's fast, and we know it's going to get penetration into surgically aerated cavities. Great.
So I'm going to skip through to a couple of cases. I mean, these are the goals of surgery. Everybody's aware, and they've been highlighted in some of the prior talks. Surgical outcomes, again, we'll skip over this slide, but bottom line, great data to show improvement in quality of life, validated scores, great data to show improvement in associated comorbidities, including lower respiratory disease. Revision rates can be high with particular disease entities. AFRS, if you leave any fungal elements behind. AERD, because of the underlying nature of the disease, although perhaps biologics will change that revision rate for us, and there's some data that's been published that indicates that it likely does. So I'm going to play through some of these videos, and I'm going to ask Sanjay to comment on this. So here you've got a coronal CT. This is a 48-year-old female, left facial pressure, proptosis of the eye, some supraremedial lid swelling. Endoscopy, you've got this non-friable, somewhat smooth lobulated mass. A bunch of allergy testing. It's positive for penicillium mold and a variety of other things. I'll play that video again. In the meantime, I'll also keep this going.
The key here is the unilateral nature, erosion of the lamina propria, and some sort of heterogeneity I'm sensing within that, sort of that serpent, this snake-like, which really points to sort of AFRS as a sort of leading diagnosis here. I think proptosis in particular is a high correlation with AFRS over other types of chronic rhinosinusitis with polyposis. So that's on the lead of my diagnosis as a possibility here.
Great.
That's a really nice example of the windowing we were kind of talking
Exactly,
about.
yeah.
It's kind of tough to tell in that one, but it's not very tough to tell.
On this one, it's very, very obvious. And in the MRI, you see the same sort of voids that we were talking about before.
And that heterogeneity of that content within maxillary sinus, very typical, I think, for me, for AFRS.
So I think some of the prior talks kind of emphasize the importance of removal of all disease. Jeff, how do you do that? You just make massive openings up front? How do you ensure you get everything out?
Yeah, you just have to be confident that all the stuff is out. So then you base your openings on the fact that you need to get everything out. So if you're looking into a max radius sinus, you use an angle scope and make sure the floor is clear. If it's not, you figure out how you can get it clear. We have lots of different devices, whether it's hand irrigation, different mechanical, high-powered washing devices, and whatever you have to do.
Let's say you do get it all out. How do you manage them in the long term? Are you just going to say, okay, well, I got it all out. They're good. I'm just going to let them run? Or do you put them on topical corticosteroids, a burst of oral steroids afterwards? Again, a little controversy here. What do you do? Jeff?
Yeah, so for me, for most of my patients, I know it's controversial these days, but I do antibiotics and post-op oral steroids. I just feel like it helps them get to normal a little bit faster than if you don't do oral steroids. But if there's reasons not to give oral steroids, I don't, and then I'll just start the topicals much faster. But I typically like oral steroids afterwards. I like culture-directed antibiotics. I really want to inspect the cavities. What I feel is that if you can get them to normal, it's easier to keep them normal once they're normal. If you get them, pretty good after the surgery but never normal, then you're likely going to fail at some point.
I think there's great data to support that. If you can get them normal in the first 6 months, do whatever you have to get them there. I was interested, do you tailor that at all? Is it based on what you see, how much or systemic steroids? And the antibiotics, are you really giving them for just coverage of the fact that you've cut into the nose that much? Or is it for that you think that there's a portion that's going to help with the immunomodulation or something?
Yeah. So at my hospital, we're the team doctors for like 2 different sports teams. So I've noticed that if I give my typical 20 milligrams of prednisone post-operatively to these guys that are like 280 pounds, 20 milligrams of steroids doesn't do anything. So I give more now. So I'll give the dose that I feel will work. And if I feel at the first post-op visit, which is in a week, if the swelling isn't down like I want it to go, then I'll actually increase the dose because I really want them to be normal at some point, and I have this very short window where I can get the mucosa under control.
I do the same thing I'm very aggressive in my eosinophilic population to get them there. That's my chance. And I'll throw the kitchen sink at it because once you get them normal, keeping them normal is so much easier. If you never get it there, you're sunk.
Greg, how much longer do we have? Another 5 or so, or are we done?
We're pretty much done.
Okay.
Go ahead, wrap it up.
All right. So in the last few seconds here, AARD case. The key question here for me is, do you ever consider going aggressive up front? I'm just going to end it with that, and I'm going to ask Arif, and anyway, I'm just going to open up to the panel. Let me know your thoughts. Do you go aggressive up front? And what I mean by that is, do you just go straight to a mega antrostomy, straight to a draft 3? There are folks in Australia and the like who are big proponents of this.
Yeah, this is not a 1-minute question. and I won't suffer Greg's wrath. Listen, I think that both sides of this argument become that I think you can, and I think there's some people who need it. And the hard part is you have to have the experience to have seen, and I saw Jeff's pictures and videos about, is that going to fail? There are some people, though, we should give them the chance to fail because that does take effort and costs something, a lot of exposed bone, healing that comes with that, what that's going to mean. And so the question is, I've done both, and I do upfront primary draft 3s. I'm still not certain that they wouldn't get better if everything looked great. The hard part is I can't make that decision, like Greg says, as a game time decision. Because then they've been pre-medicated with steroids. Everything looked pretty good, and I'm thinking, well, do I need to do this? That part, I like making that decision ahead of time.
Okay. Great. Thanks, everybody. Appreciate it.
Thank you.